So we do have a packed agenda, so I'd like to move on then. Thank you again, Dr. Ferguson, to our next presenter. Today we have the privilege of being joined by John Short, who is the Chief Technology and Integrations Office within the office for the U.S. Veterans Affairs Office of Electronic Health Record Modernization. And it's through John's instrumental leadership that the Office of Electronic Health Record Modernization has successfully migrated more than 101 billion VISTA health records of almost 24 million veterans to the VA's new electronic health record solution as of August 2020. Very impressive. Today, Mr. Short will be sharing lessons learned and providing with an expert overview of the VA Health IT Modernization Project. As I mentioned before, we have a long-standing relationship with the VA in our RPMS endeavor, as well as looking to you for leadership as we move into the next phase of health IT modernization. Again, I want to remind you to please reserve your questions or comments for the Q&A portion of the session, or to drop them in the chat box. And again, being able to submit any questions following the conference as well via email to NIHB. So welcome, Mr. Short, and I'll turn this over to you. Thank you.
Thank you very much. Appreciate the time, and good afternoon to everybody, or good morning if you're on the West Coast, or Pacific Islanders in Hawaii, et cetera. So thank you for joining today. I appreciate your time. I would like to also say that, most people already know this, but the VA has a long history of supporting different initiatives in Indian country. There's a lot of veterans, as most of you know, from across the tribes, across the nation. Many times, Secretary Dennis McDonough and new Dep Sec Donald Ramey, who came on board several months ago, they also fully support any work we can do in support of Indian country and healthcare initiatives, especially where it comes together with the veterans. VA continues to support also RPMS and integration with VA CMOP, Consolidated Mail Order Pharmacy, where they can fulfill pharmacy orders that come in from different facilities. So without further ado, if we can go to the next slide. Hello, next slides. So a few updates on the program, different things in the news. There's a comprehensive lesson learned report that came out shortly after Secretary McDonough came on board. He asked for a full assessment, end to end, top to bottom, side to side. Program had been going for about 2.5, 3 years. And we'd had the Joint Health Information Exchange go live and be upgraded. We migrated 24 million veterans records and integrated that, semantically interoperable. We went live with one site with a scheduling system, and went live with another site with a full suite EHR. And it was time to get a full assessment, especially with all the impacts of COVID, and make sure that adjustments are being made to account for that as well. So that report was put out, lessons learned and adjustments, many of which were actually implemented even before the report came out, as the agency tries to implement anything where as it discovers it, and it can improve the process, be more efficient. So actually, some of the items as it came out of the report were already being implemented or were implemented, and many more underway. The Deputy Secretary, again, Donald Ramey, he veteran himself, U.S. Army, who he's really focused on, he's the single owner of this for the agency. I think it's important, whether it be in Indian country, whether it be in commercial, you need to have someone who is the responsible authority executive. At the end of the day, they have to roll up to somebody. And he is that person in law, and he takes that ownership seriously and spends a lot of time personally, and the staff do, on the record to make sure we have the right thing for the agency and for the veteran. With patient safety being a key driver, obviously, and having that single longitudinal record for the veteran. Successful deployment of the EHR is essential for the lifetime from The MEP station, when the soldier first went to get evaluated to see, or the individual to see if they can go into service as a soldier, sailor, airman, Marine, through their continuity of care, DOD, when they transition to VA, when they can no longer care for themselves, they have a caregiver, and when they pass away, and still having that patient record available for them and their family, and provide them benefits from that data along the way. And that's why it's important to have that successfully integrated together. VA is in tight coordination with DOD and certain partners, and although Coast Guard gets lumped in with DOD because they've deployed with DOD, they're Department of Homeland Security. So we're also in coordination directly with Coast Guard, but mostly through DOD with them. I'll mention that they recently completed their U.S.-based deployment about a month ago. So we're the last one of the 3 agencies to start, but they finished their U.S. deployments, and they have a few overseas. So a lot of good success there. But we're in tight coordination with them and Cerner and the other partners to make sure that we have, high quality healthcare delivery that the veterans expect and that Congress and the American public demand. Next slide. So the new electronic health record will be the single source for veteran health information and for patients and providers. As mentioned a couple of times already in the intro, and I mentioned, we migrated about 24 million veterans records, 23 million plus, to Cerner from Vista, 29 years of records. I believe the oldest record was October. It's a lab record from Salt Lake City. It was the oldest record in there that we moved. And we looked at different ways to move the records. We ended up copying the records to encrypted storage devices and VA security along with Cerner security, migrated the devices to an airport, flew it by plane, and then along with armed guard security all the way to the Cerner data center, plugged it in, updated it, and then turned on a connection over the wire to keep them updated. Many other systems besides Vista have also been moved in there. We didn't just move the data. Anybody can move data. I mean, moving data, even if you can't spell data, you can probably move data. But we did more than move data. So we spent a lot of time with clinical informaticists going through all the legacy data to clean it up, where Tylenol was spelled wrong, or where something should be capitalized and wasn't, making sure all the national codes, these LOINC, RX norms, SNOMED, these national standard codes were all in there properly and updated. So they did a lot of that work first, then we migrated the data. Then Cerner has a whole set of tools we went through to clean up the data, make it more usable, make it more interoperable for DOD and with community care partners. Now, by doing that, what we did was we made all that data from multiple systems, DOD legacy data, VA legacy data, DOD and VA new data from the Cerner EHR, as well as community care data coming in from the Joint Health Information Exchange, all combining in so every veteran has a single longitudinal health record end to end from the MEP station to the time that they pass away. Now, DOD hasn't moved all their legacy data in there yet, so some of that is still to come. They've moved about 3 years of data for the PAMPI domains, problems, allergies, meds, procedures, immunizations. They've moved those, and they're looking right now at how many more domains they're going to move and how far back. They've already started a process of moving additional legacy data, and as they add it to a platform called Healthy Intent, it's next to the Millennium EHR, that will pin that record. And so the ultimate goal that Congress has been pushing for many years will be satisfied with having one single record everywhere. So the patient goes into their portal, the clinician goes into the care application, no matter who looks at it, they all see the exact same record, everything. Now, in my case, when I came to VA as a veteran to get my physical for benefits, they said, "Oh, we're sorry," and no offense to DOD if they're on the line, "We're sorry, but DOD, Department of Army contacted us and said they lost your medical record, so we can't do your examination." I said, "Oh, wait a minute. I was told before I leave the Army to make 3 copies of my medical record, 2 for the VA and 1 for me." And so I left my original with the Army, but I have 3 right here. And I gave 2 to VA, and they went, "Great." We did my exam. So glad to know that I made a copy of it. Good for me. Several other veterans have done that. However, that should not be the responsibility of the veteran. The record should just be there. And so a part of this will provide that. So VBA, Veterans Benefits Administration, is tied into there. They're the single user of that record. We're continuously developing more and more processes and applications inside the EHR, tying directly to all the benefit systems, with the ultimate goal of VBA being able to adjudicate someone's records as they're in service, and by the time they leave, to actually know, hey, you're 39.7% disabled or whatever, you know, their number come up with. So not saying we're there right now, but the goal is to shorten that time frame. So this presents this so they can make the best determinations for the best patient outcome at the point of care. The veteran can also see the same record. So from their perspective, there's no mystery between what the provider sees and the veteran sees. I will caveat that there are a few business rules, as many of you know, work around clinical activities, that some records you don't share with a patient in any sector immediately until the clinician tells them, like cancer diagnosis, mental health notes, et cetera. So there are some business rules where there's a delay of so much time, a week or 2 weeks, where certain pieces of data may not be available to the veteran. It's available to the clinician because they need to talk to the person first and go through that process. But other than those business rules that are intentional, the veteran will always see the exact same full record that the clinician sees, which I think is a wonderful thing from a personal standpoint as a veteran, and as I think from all the care providers, other veterans I've talked to. And so this also improves and enhances collaboration between different providers across the full spectrum. It brings dental, instead of being those dentists over there, they're pulled in more into the core EHR to be part of the full healthcare system. As many of you know, issues with dental can cause cardiac disease. So having that whole health and tying the whole record together helps with that single longitudinal record. Next slide. So on the roadmap, I talked about some of this already. So there was an announcement in 2017 by a former secretary that we're going to be moving to commercial joint DoD on this, not a copy of the same system, not the same version of Cerner. It's one single system. Now, tons and tons of servers. Okay, so don't get that wrong impression. But when DoD's in there typing away, we see it as we're typing because we're all in the same record, right? So it's one single record. So we joined DoD and what they already deployed. We added additional capabilities. As we went through that process, we then awarded a contract in May 2018, and that included developing 3 RTMs, requirement traceability matrices, one for functional, clinical, administrative, and business, so all the functions of the hospital, full gamut. And then, and that included also the VBA requirements for their functions, and then a technical RTM, requirements traceability matrix, that was built primarily by OIT with some input from the functional staff. And then there was the innovations RTM for things that people wanted to move to in the future that we put on the roadmap. All that came together with the contract and it was awarded in May of 2018, along with some advanced interoperability functionality that you'll continue to see being released in the near future. In June of 2018, we also provided, we established new management oversight. The law EHRM program was created, had its own dollars. Congress mentioned new EHRM dollars with its own appropriation. And then December 2021, under the DevSec's direction, we've now modified some of the governance and management structures. And I'll get into some of the steps we took along the way. One of the items I'll mention in the middle there is the Deputy Secretary, Donald Romney, recently mentioned a new Program Executive Director, PED, for the EHRM Integration Office, Dr. Terry Adirham, coming from DHA. So she'll be fully on board next week, and we're looking forward to her being here. Next slide. So let's look at some of the progress we made along the way. As I mentioned, the joint HIE, this is the first one, April of 2020. So we launched that initially with over 200, healthcare networks, over 2,000 hospitals, 9,000 pharmacies, 35,000 clinics, 1,200 labs, 300 nursing homes, et cetera. Huge health information exchange. And this allows us to, not just for the site that's going live with Cerner, but every legacy site is also using this HIE through what we call the Joint Longitudinal Viewer, which gives us all the DoD data, the VA data, and the community care data as one record for viewing. You can't enter data in there, but you can view all the data. So interoperability record viewer for all the different records. And so Vista sites, that the last Vista site that'll be transitioned to Cerner, they're using the Cerner HIE for care day-to-day right now. Then we launched the centralized scheduling solution, CSS, in Columbus, Ohio, based on the Cerner system inside the revenue cycle package. Included about 10 different interfaces as part of that rollout. And then we did transfer patient data, getting ready for the Columbus go live. Now I talked about moving the 24 million veterans records. So we moved that into, again, healthy intent, normalize that data. That's a key thing I think you should really look at. And Stewart Ferguson talked about that to some degree, about moving data and the value of that. So we moved all that data into healthy intent. And again, we normalized it, made it completely interoperable, semantically interoperable, and clean that data up there. But then prior to a go live, really very close in the 3 or 4 weeks before go live, we move the piece of that data for all the patients that typically go to that site in the last 3 years. We move that data into the EHR. You don't want to have everything in the EHR and get it too busy. So we leave that data in the population health tool, and then we move the patient load for those facilities as they go live. So that's what that transfer is talking about in that perspective. That this includes active orders, active meds, active labs, all that kind of stuff would be what would move over. And then the active orders and labs actually cut over the night of cutover, because you want those at the last possible second. So we do all the patient data for that patient load for that facility, and then the night of, we do the active orders. Then in October of 2020, we also upgraded the joint HIE to include additional nationwide private sector network of additional 15,000 hospitals and clinics. Today, we believe it's the largest HIE on the planet, but I haven't seen Guinness Book of Records notate that yet. Then October 24, 2020, the EHR full system, what we call Capability Set 1, which is initial full suite of applications for small to medium hospitals, went live, along with the West Consolidated Patient Accounting Center in Las Vegas. Now, people talked about, well, went live in Spokane. We have one side live. Well, there's also 4 different community-based outpatient clinics, like an urgent care kind of clinic that went live at the same time. Additionally, we have people go live in 14 states that support man grant staff. There's a 5-person call center in Las Vegas. I mean, in LA. There's other call centers across the country. There's patient advocate offices. There's reports and registry offices. So when we went live at man grant staff, we had over 800 people across the country that support man grant staff prior to Cerner and after, also went live. So really, it was a very large go live just for that one facility. And a lot of the things we did at scale for enterprise. As an example, the CMOP I mentioned before, the Consolidated Mail Order Pharmacy. And again, some of these things what you need to look at as you're looking at your planning on the tribal level. Anytime you can do stuff at the enterprise, one and done, that's what you should be doing. So like we did integration for man grant staff for all 10 CMOP, and all the integrations are now done for every facility. So yes, there's some validations we do. We go to another site to go live, but there's no more new interfaces to build. That's already all built, all tested. We took care of that the first time. So you should look at that wherever possible, build the enterprise interface integration so you're not building a bazillion interfaces if you don't have to. You want to decrease the complexity wherever possible. Next slide. Here's some stats on the patient portal. There's been over 17,000 people that signed up to use the patient portal since October of 2020. They're actively using it. 21,000 signed up. Could be like me when I first signed up to the VA portal as the individual veteran. I signed up for it, used it once, and didn't use it again for 4 years. So I guess that might be why there's 17,000, 21,000. Not sure. But there's 17,000 active users. Has a high uptime reliability. There's been 101,900 medication refills requested through the portal and fulfilled, and as well as 12,000 renewals. Renewal is, hey, my refills are expired. Can you please reactivate my refills for another year? That's what that is. 30,000 messages sent, general messages, and 56,000 total messages sent. That's where the veteran's saying, hey, doc, this lab says X, Y, Z, what does that mean, or whatever? Or can I get an appointment next Tuesday for my sore toe? So that's what you see there. So very good utilization on the portal side. Next slide. And I will mention, I think Stewart was the one who mentioned it. There are also incorporated in the portal where a patient could do self appointments. That was turned off for the Cerner portal and the legacy VA portal for COVID because hospitals are having such a difficult time managing their workload and patients scheduling stuff and having separation for COVID rules. So that was turned off for a long time. VHA recently changed the policy to allow hospitals one by one, based on their choosing their facility and their COVID level, to turn that back on. So you'll see probably some more stuff on that coming soon. So on this slide, lessons learned. So again, adopt an integrated approach to your site readiness strategy. What does that mean? Well, it's not just about the EHR itself, as a couple of different presenters talked about. They talked about IT transformation, I believe some of them said, but you also have the physical plant. So you might have to add a new chiller unit, a new cracker unit for your data center at the hospital for some new equipment you have in there. You might have the VA, we had to have some roof repairs. There was a leak in the roof. Obviously, EHR didn't require a new roof. The roof was needed beforehand. So you need to coordinate the physical plant infrastructure, the IT infrastructure, the biomed infrastructure. You need to do it early. You need to do it together. I have about 2 feet of integrated plans that have been negotiated between VHA, OIT, EHRM about how we work together on biomed, on local area networks, wide area networks, telephony, wireless networks. And so you need to have all the stakeholders all integrated into a plan of action on what standard we're going to use, when we're going to do it, et cetera. So there's no misunderstandings. And I would say it's difficult to do your infrastructure too early. Now, I would say that before the supply chain issue. Now the supply chain issue on steroids, I would say that. So it pays benefits early for your current state, and it'll pay benefits to having a smoother go live. Also, you need to recommend you leverage an IOC, initial operating capability strategy, because that will allow you to get lessons learned and take those and incorporate those and optimize your deployments for better user satisfaction. We had about 124 or so workflow optimizations that came out of the initial review from the first deployment, as an example of that. Access and upgrade infrastructure. You need to get the access right up front, early, test the heck out of it. Again, upgrading the infrastructure around health IT, biomed, is critical to do that early and test the heck out of it. Cerner told us that we did more testing than any of their commercial customers and DoD. So, and people still want to do more testing. So again, do it early so you can test the heck out of it, especially for your first few sites so you can really get it right. Refine functional technical quality standards as needed. So, make sure you have good metrics, was one of the things we did, but also you monitor those and then continuously, as soon as you start getting some lessons learned and you validate, it's not just an anecdotal thing that's really going to have value, start incorporating those. Don't wait till you get a ton of them. Immediately start incorporating those in an agile fashion, like rapid software delivery. Just constant business process improvement, taking that stuff in, and it will continue to pay dividends for you and make your life easier. Develop a pay it forward program. This came primarily from DoD. I'm not sure if they created it themselves or got it from someone else, but where they have clinical, business, administrative staff from one side that's gone live. They've been live for a while. They will deploy to another side that's going to get ready to go live. And so they've been using the system. They've learned the nuances. They're confident because they are the one doing that job. They are the only ones that can instill the confidence in that user. Say, hey, I'm doing the same job you are, across the country, and this is how it works. You're going to be okay. And so DoD has found that tremendously valuable. They can't say it enough, and VA is also going to be copying that model. Next slide. Stages of interoperability. So the determination of findings document signed up by the Secretary of Veterans Affairs to move down the Cerner path had the primary focus of interoperability. Congress is constantly focused on interoperability. So we have the interoperability within VA, as someone else mentioned. RPMS doesn't really talk to each other, and you have some minimal sharing of data, but you don't really share data, not really truly interoperable. And so you have the intra-operability in between all the different VA sites, and being on one system, you get that. Next is being on one system, we get the full interoperability with DoD and US Coast Guard. instead of having these different records and stacks of paper like I brought to the VA and et cetera. You've heard about those stories before, I'm sure. Then you have interoperability, the next layer with community care providers, whether that be TRICARE with DoD or with the community care system with VA, or just somebody goes out to some doctor on their own and they want that record to come into the VA. Making sure we have full interoperability sharing back and forth, really key and critical. And then national interoperability, which is filling in all the other pieces and parts, whether it be a small lab, whether that be a testing facility for COVID, whatever it is, to have all those other little providers that aren't really necessarily a hospital system, et cetera, but all the little onesie twosie, the one doc shop in Anchorage, Alaska, whatever, so that sort of thing, where you start filling in all those. So that piece is still being worked on, because if they don't participate in the HIE, Health Information Exchange, then you have to do other things to be fully interoperable, which is being worked. Next slide. So what can tribal leaders learn from VA expertise? Adapt training to end users. So especially with COVID protocols, et cetera, we've looked at computer-based training. DoD didn't have a lot of success in that, but we're looking at different ways to do that. We've looked at having virtual in-person training. So instead of being in a classroom, you can be virtualized, but still be instructor-led training. But bottom line is, you have to look at your providers, the way you're at, and the way your EHR provider, your best practices, and kind of blend that together and come up with a model, and be ready during IOC to take lessons learned and just fire on those things. Another thing that VA has a lesson learned is to build a sandbox where it has a lifelike environment, that copy of production, that people can try different things, they can test out new workflows, they can test out new medical devices, et cetera, so they can do advanced training and study to inform them on maybe some changes to make for the workflows, or ways to train better, ways to improve care for a center of excellence, that sort of thing. Next slide. So planning for the future. So after VA had its strategic review period, we went forward with our deployment activities for Ohio, Idaho, Washington State, Alaska, Michigan, Wisconsin, Oregon. We have all those activities going on for deployments. On the infrastructure side, I'm working almost half the country with all my technical teams and VA's Office of Information Technology. So that you have that going on again, because we're doing infrastructure work. Some areas I have to buy infrastructure 3 years before the site goes live, because it takes 4 or 5 months to do the acquisition. It takes sometimes a year to get that product. That's prior to the supply chain issue. Then, in the case of a computer, maybe 3 or 4 months to get an image, another couple months to get them all deployed. And all of a sudden now I'm 18 months early, and now I'm doing my initial testing and connectivity, and now I'm fully done 1 year early. Oh, that's our goal, to be done with infrastructure a year early. So some acquisitions for infrastructure are 3 years before you go live. That's why I say you needed to do it as early as possible. That way we're VA in this case is ready for our deployments of 22 and 23. So you have training, in user adoption, infrastructure, site readiness is the path that we go through. There's one other one, which is the site readiness. We have a current state review to go through at the sites 24, 28 months before the site goes live. We do a current state review, look at everything, physical plant, IT, workflows, clinical care, specialties, et cetera. And that incorporates and informs training and the build for the site. Next slide. So we have a few minutes left for questions. I will say, I just want to add from a personal note, I had some previous experience before VA where I supported the Eastern Band of Cherokee Indians with some different initiatives for telecommunications and whatnot. And I spent a lot of time with FCC and different tribal initiatives. There's a lot of challenges out there, and I'm not saying anything that probably most people don't know already. And so getting that bandwidth into some tribes where some tribes at that time, when I was working with FCC, had party lines. They had to wait several months to get an individual phone line for an individual, or there was no internet connectivity or minimal, almost non-existent internet connectivity. So those are the things we really need to have available for Indian country to make sure that you can be on the cutting edge and be on the modernization path for the EHR and your IT system in general to support your tribal members and their families. Thank you.
Thank you, Mr. Stewart. Do we have any questions from the audience for Mr. Stewart? You can either use the raise hand feature or drop your question in the chat. We do have one question from Mr. Jeffrey Roth in the chat. The question is, when did modernization planning begin for the VA? How have the cost and implementation timeline estimates changed over time? And do you have any feedback on cost and timeline of implementation given IHS sites are 70% rule?
Okay, that's in the chat. That's a lot of stuff there.
Yes,
let
sir.
me see if I can get that. All right. So well, there's all different kinds of modernization stuff always been planned at VA, but for in this case, towards the end of 2016, VA started looking at, which way we're going to go. Laverne Council was here at the time. I was a single Vista system owner for all the Vistas in the enterprise. First time we had a single person instead of having it by region. And I put Vista on a path to get healthier. They were on 4 different platforms, 3 different versions of Linux and 1 version of VMS. I got them all to 1 version of Linux, 1 version of intersystem cache, got them all encrypted, etc. Got the data cleaned up. We were doing all that because we didn't know, are we going to go to some type of new modernized single Vista in the cloud? Are we going to go to a commercial? No matter which way we went, we needed to get the Vista system healthier and the data in a better state to do that. So we started doing that in 2016. And then in 2017 was the planning to go towards the Cerner EHR, which was announced in June of 2017. And throughout that time frame, there's constantly been modernization planning going on, and there still is. From a tactical level, every Friday we have a Get to Green meeting. So we're looking at sites 2 years out, and we need to replace a roof and a cracker unit. Can we get that done in time? And get it contracted? Can we get the construction work done and all that, and be 6 to 8 months, 9 months, 10 months, a year early before the site goes live, or should we push that site off and go to another site? So we have that type of level as well as enterprise level. The CIO and his staff are looking at all the modernization along with Undersecretary of Health, prioritizing what should be modernized and what should be moved into another system, that sort of thing. The estimates change over time. The EHRM estimate itself has not changed, although we're undergoing a full life cycle cost estimate right now by an FFRDC called, I just forgot the name, IDA, a defense agency, IDA, sorry, I just forgot the name. But there's the jargon for their acronym. And so they're doing a full life cycle cost estimate currently right now, and that'll be done in about 8 to 9 more months. Feedback on cost and timeline of implementation given that IHS that are 70% rule. So for the most part, because I'm working now in about half the country doing infrastructure, I haven't found a lot of different issues infrastructure-wide in the rural sites. The little CBOC in the middle of nowhere. Some of them are right in the middle of smack dab, Indian country, right next to it, Coeur d'Alene, et cetera, in those areas. And some are right downtown city. I haven't seen that many different issues in that regard, except for one, which is always the one that haunts anyone in the rural area, which is the bandwidth, getting that wide area network right. And so that's where I think we need to work with FCC and those different grant programs. I helped do one in another job previously and helped Eastern Man Cherokee Indians and several clinics get all connected by fiber. And I think that's what you need to get to. You need to have that right connectivity, that, some neat wireless connection or some satellite connection might be neat backup. But my professional opinion, many years in telecom, we got to get fiber to Indian country for the upgrade. That's where that needs to be. And you need to push into FCC for that, in my recommendation. Over.
Thank you, Mr. Short. And we have time for one more quick question from Keith Bill.
Thank you, AC. John, I am a Vietnam vet, and I got served from 69 to 77. And as you know, that the VA had a big fire in their warehouse for our historical stuff. And like you said, some of the records were lost. And if I was listening right, you said that you're working with the DoD, which means our active service brothers and sisters, to transfer over to the veteran status that their records would follow. And you and I both know that when we got out, most of the Vietnam vets never seek care, and some of them are still not even seeking care. So when we go looking for the records, like you said, some of them are there, some of them are not. But I was just wondering if we are doing that for the veterans that got out of the service, World War II, Korea and Vietnam and Afghanistan before we started working with the DoD and the VA to have their records follow. Are we working on that to make sure that like I will just use myself as a Vietnam vet. Would my health records from 69 to 77 be available to me? Because when I go to the VA and ask for their records, I have asked for them for 3 times now, and I still haven't received my health records.
Well, Chief Bill, thank you for your question, and I'm sorry that you haven't gotten your record yet. As much as it means to you, my apologies for that. So obviously it's a mixed bag, right? Because it's not a perfect world. If it's computer format, that's obviously easier and faster. Again, VA, we moved 100% of everything we had in the record into the system, even patients that are dead. So if it's a former VA patient that was passed away, their records got transferred to. It's all there for the researchers to use. And one of the reasons we did that was because we wanted to be able, for people that are still alive, there's a lot of outcomes that are in that data to help people. As an example, one of the things that was discovered through VA researchers is if you were in Vietnam and you got exposed to Agent Orange, you had a higher incidence of potential for colon cancer. And so the doctors go, hey, I got a reminder here. You look like you had this exposure. Let's get you on a more up-to-date test to make sure we're checking you out, that sort of thing. And hopefully that's not your case. Not to scare you, I'm just saying that's one of the benefits of getting that data in there. Now, how do we get this data that was written on some medic did a little scroll card in the field? Like when I was a combat medic, when I was enlisted before I became an officer, and I filled out this little paper card, this plasticky paper thing. If you ever saw one of those and tagged it to a soldier, how do we get that into the record? Well, I mean, obviously, like it's not electronics, so it doesn't move automatically. But there are multiple different efforts where parts of those records are being digitized. As they're digitized, they were going back and pulling that data. So as soon as we're able to get any of the records that have been digitized, move it over. Is there a singular initiative to look at all the old paper records, get them all digitized in a way that can be made computer readable? There's not an initiative yet. There's a lot of people that want to do that. I would support that if someone made that an effort because I think it's important for yourself and other people like you to get that in there. So as those become available, they'll put it in there. And again, my apologies, you haven't received your record. If there's anything I can help you personally, please feel free to email me and I'll try to assist you with VBA. Over.
Oh, Arta, thank you. And yeah, just like you said, I do a lot of mine through the Indian Health Service. So I hand carry my doctor's papers over to the VA and have to have them put in manually. And this is, you know, back when we were thinking as veterans being served by the Indian Health Service and the VA, that the two systems would be able to talk to each other. So I don't have to take the same blood test at the Indian Health Service as I do at the VA and get everything repeated. Just this last trip I made up there a couple months ago, my doctor says, well, why don't you just bring your blood test from the Indian Health Service? And I says, I can do that. I got it right here on my health for the Native Health Service. And I also got my health for the VA. We need to have a bridge that will.
Yes, sir. We are working on parts of that, the HIE, so I'll do some follow up on that as well. It sounds like currently part of our interoperability solution is Chief Bill, which we don't want that to be the long-term solution. So thanks for sharing your record, and I apologize you have to do that right now, and we look forward to making that better for you.
Thank you, John. Oh,
Thank you for your service.
Thank you, Chief Bill. Thank you, Mr. Short. If you have any additional questions, feel free to put them in the chat. The contact information is on the screen, and NIHB will make sure to get that to the VA. Next, we'll be taking a short break.